Hi. So welcome to another edition of MD PhD lecture series on Intro to Psychiatry. So again, this is aimed at a number of different levels. I'll be talking about everything from maybe where a psychiatry intern would learn to hopefully some things that the general public will find helpful, or if you're a nurse, tech, other things. So hopefully everyone will find something a little useful in here. And today we're going to be talking about depression. I'm sort of off to one side here because I'm experimenting with the idea that hopefully some slides will magically appear over here, or my ugly mug will get replaced by some useful slides as we go through here. So let's talk about depression and what the heck that means, because you'll hear this tossed around a lot. You know, what does that word mean? Because, of course, words have been around for a long time, and in a common parlance, depression may mean just sadness. I mean, we've all been sad, right? Does that all mean that we've all had some sort of psychiatric illness that needs treating? By no means. So, I mean, it could mean sadness. Could it mean something that's just more severe sadness? Are we talking about a situation of despair, of hopelessness? Is that what we as psychiatrists or mental health folks are trying to help? Or, if you've seen the Zoloft commercial with a little bouncy ball on television, maybe that's a thing of the past now, because Zoloft has been generic for a long time. Maybe people don't remember that. But, there's a lot of discussion about that this is a biochemical abnormality. And there are things that we know about people who are depressed, and that they have maybe biochemistry that is a little different than people who aren't depressed. But there's a huge amount of variation in there. But is that what we're talking about? Are we talking about a biochemical abnormality? Well, in psychiatry in general, one of the great innovations that has occurred in psychiatry over the last 50 years or so was the invention of the Diagnostic and Statistical Manual. And this was invented as sort of a dictionary because for a long time, psychiatrists talk about words in very different ways. So one patient would supposedly have schizophrenia, which most of us now think of as a very sort of biochemical, almost medical illness. And they would see an article that someone wrote about that they were cured of schizophrenia through talk therapy. And so psychiatrists would run out, try this, and guess what? It didn't seem to work on most of the people who seemed to have schizophrenia. And that was partially because we were using the words in very, very different ways. And you still see this in the psychoanalytic literature, where when one psychiatrist talks about, say, transference or psychosis or neuroses, that they may be meaning very different things. And then that also makes the literature somewhat annoying in that often a third of the beginning of the paper will be spent defining what they mean. So, when we use a word, we want to use it very precisely. As the quote from Alice in Wonderland, or Alice in the Looking Glass, I'm not sure which, from Humpty Dumpty, great scholar, said, "When I use a word," Humpty Dumpty said in a rather scornful tone, "it means just what I choose it to mean, neither more nor less." So psychiatrists decided to invent basically a dictionary that said we're going to define what we mean by certain conditions, so that when we're treating something, that a doctor in Belgium or one in Los Angeles or one in New York can all agree on things. And this has gone through various revisions over the years. In the first versions, it looked like any other dictionary. It would just sort of be a descriptive things. Real innovation came in the third version of this, DSM-3. We started using checklists to say, okay, we have this. If you meet this whole checklist, you have a particular condition. So sort of a list, and this gets made fun of sometimes as sort of like the Vogue quiz or Cosmo quiz version of psychiatry, where if you have these various things along there, that you have what we're going to eventually call Major Depressive Disorder. But it's more than just the checklist, because ideally there should be some external observation of this, not in terms of just checking off things. There are some diagnoses that are very reliable in terms of the checklist from self-observations, and depression may be one of those. There are other ones that are clearly not. Bipolar disorder is the most obvious example of this, that if you ask anyone to fill out the checklist for that their reports and what a clinician sees may be vastly off. But for depression, this list, this definition, can be very useful and can lead to treatment. And the idea here is, before we get to the issue of whether this is a biochemical abnormality, whether this is something that, say, comes from your childhood, whether this is anything else, we first have to be able to examine people who we all agree have a certain condition and then say, well, do they have a biochemical abnormality? Do they have certain childhood patterns? So we have to define them the same way first. And essentially, this works the way medicine did in the 19th century, which is that we were working on pattern recognition before we even really understood the biology. So physicians were able to treat the flu long before we knew what the influenza virus was, because people could recognize a pattern. We could say something reliable about that. And then based on the fact that we could find all these people with the same condition, we were able to discover the influenza virus by finding out what was in common among the people who suffered from this condition. And that's hopefully what the diagnosis of depression does, and why it's worth learning and understanding. Because the first part to being able to treat anything is to be able to reliably identify it. And within the diagnosis and the concept of DSM, there has been some question of a trade-off between what's called reliability. And reliability means that any two people can diagnose something the same way, versus validity. The validity means is what we're talking about, even if we're fudging a bit, we're getting to something that is truly deeper to that, to some sort of fundamental, say, serotonin deficit syndrome. And places like the National Institutes of Health have very much wanted to move towards a more valid diagnostic system, something that talks about underlying biochemistry, but on a practical level for clinical use. That these checklists that are in DSM are actually much more useful, because the biology is incredibly complicated. We're probably still decades away from really being able to, say, have a lab test or brain scan that definitively is the way of diagnosis. But in everyday use, doctors in offices everywhere, and psychologists, nurses, can start to identify a particular definition, and depression is really sort of the archetype of this one that really helps you to understand what is there, because that allows it to be reliable. And then hopefully reliable means that we do discover something valid. So without further ado, what is the definition of what we're going to talk about? And now, so because that word just depression gets sort of fudged, it might mean, in common parlance, just sad, we're gonna use more particular words. So we're not going to talk about depression in the general sense, though that sometimes does still get used. Heck, I've been using it in this lecture, right? We're going to talk about specifically, though, a major depressive episode, and then whether that major depressive episode is part of major depressive disorder. So first of all, the definition of a major depressive episode. So there are 9 criteria for defining a major depressive episode, of which you have to have at least 5 over the course of 2 weeks, present the majority of the time. Now that may seem like a relatively low threshold for defining something. You're sad for 2 weeks, you have some other things going on. But again, this is based on statistical modeling in terms of what supposedly is, common within the general population and not. In theory, the DSM uses the definitions and basically keeps refining them until we find something that is both reliable and valid, and really differentiates what's sort of a part of the, quote, average population and part of the more clinical population. It doesn't always work this way in real life. There's a lot of politics in how things are defined. Thus, minor depressive disorder was jettisoned from the Diagnostic and Statistical Manual as much because this term sounded like maybe it was something that we shouldn't be treating as much as it was the idea that it turned out to not be a very reliable or valid diagnosis. But let's forget the past and things that were jettisoned, and let's talk about what is the current definition. It has been the current definition for at least since DSM-3, so at least since the 80s. So again, 9 criteria, of which you've got to have 5. And of those 9, 2 are considered essential. Now, in remembering these 9 criteria, they're acronyms sometimes. A lot of medical students may be familiar with the SIG-E-CAPS acronym to remember these, or mnemonic. I'm not going to go over that because, honestly, with mnemonics, my personal opinion is that everyone remembers the mnemonic and can never remember what the heck the mnemonic stands for. But I think most of us, even people with memories that are not great, like mine, can remember 3 things. So instead of trying to memorize 9 things, we're going to remember 3 groups of 3. So first of all, there's sort of the 3 essential or cardinal symptoms. As the name implies, that to have a major depressive disorder, presumably you feel sad, you feel depressed the majority of the time over that 2-week period. So that's sort of your first cardinal symptom to identify you. But sometimes within the cardinal symptoms, you may not be aware that you're sad. This can be called a masked depression. So sometimes we will still call something a major depressive episode, even if someone is not overtly reporting that they are depressed. Rather, they may report what is called anhedonia, or lack of pleasure. So you could ask someone, say, do you feel sad? They say, no. Okay, well, when's the last time you felt good, that you enjoyed yourself? They're like, shoot, it's been a year. I don't know. I used to like things, but food doesn't taste as good. Tennis isn't as fun. That there really is an absence of pleasure. And so technically, according to the definition, you've got to have at least one of those 2. If you don't have those 2, they haven't been there consistently for the majority of the time for at least 2 weeks, we're not talking about a major depressive episode. We're talking about something else. Maybe an adjustment disorder, what's sometimes called a situational depression or something like that. The third group, one that I lump into the cardinal symptoms, is not actually one that is defining of this. Technically, if you have it by itself, it's not. But it's one that if you go through DSM and you look through sort of all of the diagnoses, there's always a, consider this other thing sort of thing. And one that if it comes up, where we always want to take a long, serious, hard look at something and make sure we're not missing a major depressive episode, is if someone is having suicidal thoughts or thoughts of death. So again, 3 sort of essential symptoms of which you have to have at least one, technically one of the 2, but again, with the third, suicidal thinking, you should really go back and dig and make sure you're not missing cardinal symptoms. So the cardinal symptoms are feeling depressed, lack of feeling enjoyment, anhedonia, or thoughts of death or suicide. So that's the first group. So 3 groups of 3, we're going to talk about cardinal symptoms, which you got to have them. We're going to talk about physical symptoms, and we're going to talk about cognitive, or sort of the way we think, symptoms. So we've talked about the cardinal symptoms. What are the physical symptoms? Well, with a major depressive episode, it often alters the way that you are able to sleep, the way you're able to eat, and your overall energy level. Energy level is pretty straightforward. People are depressed, feel fatigued. Sometimes you'll hear a lot that, I sleep all the time, but I'm still tired no matter what. And this great rundown feeling is very, very common in a major depressive episode. Sleep or appetite can actually go in either direction. In a classic depressive episode, they both actually go down. Think depression, down for everything. So you're just so depressed you can't eat. So there's weight loss often associated with that. You can't sleep. And classically, this is early morning awakening. Someone is able to get to sleep, but they just can't stay asleep. That's in a typical depression, but definitely there are people who go the opposite direction. What used to be called an atypical, well, still is called an atypical depression, but differentiating the two is no longer as important for reasons that I'll go into in a minute. But among the defining symptoms are alteration is in energy level, in sleep, or in appetite. So we're going off our checklist. We've got our first 3 cardinal symptoms. We've got our physical symptoms that we've looked at. So what are the 3 remaining symptoms? The cognitive or the sort of additional symptoms. So the first one of these is just sort of negative thoughts or guilt. As you often see someone who's very ruminative, thinks about negative things all the time. They often can't focus, impaired concentration. So these are both internal, sort of the way we think symptoms. And the last one, which doesn't quite fit in, but I lump it into the last group, is what's called psychomotor retardation, or technically it's sort of a slowness, but it's the overall appearance of someone looking depressed. And in looking at this checklist, this is where I say, it's more than just something you might read in Cosmo, is that it allows the psychiatrist to sort of look at somebody and sort of weigh in on whether they think that this diagnosis really sort of fits, whether this person really looks depressed. So notice that the psychiatrist doesn't just by his or her subjective feeling get to say, yes, you look depressed, you have major depressive disorder or major depressive episode. But it does allow them to weigh in. So if you've got sort of 4 symptoms that you've checked off, I feel depressed, I'm not really having any trouble with sleep, I'm not having any trouble with appetite, etc. I've only got 4, well, the psychiatrist can kind of push that over into saying, this really is a major depressive episode. So to go over again, because it's important in making the definition, 9 symptoms, 3 groups of 3. We've got cardinal symptoms, we've got physical symptoms, and we've got cognitive and other symptoms. The cardinal symptoms are an overtly depressed mood, anhedonia, and thoughts of death or suicide. The physical symptoms are loss of energy, alterations in sleep or appetite. And then our third cluster of other cognitive symptoms are problems with concentration, generally negative or guilty thoughts, and then this external observation of whether someone looks depressed or is having psychomotor slowing. So that gives us our definition. And again, if you've got 5 that are there consistently for a week, for 2 weeks, then you have a major depressive episode. Now, is everyone who has a major depressive episode have major depressive disorder? No. Major depressive disorder is what's called an essential condition, similar to essential hypertension. And what this means is basically there's no other explanation for it. Now, the sort of tricky part when I say there's no other explanation for it is we generally think of this as something being, that is not a situational depression. This is different from a situational depression, but the actual criteria to say that a particular stress causes it has gone away. And that's just because it turned out to be a not particularly reliable or valid way to assess this. It's hard to say whether something's coming from outside, but we can tell you whether you have these symptoms consistently or not. In particular, in older versions of the Diagnostic and Statistical Manual, we used to exclude a major depressive episode if you had suffered the loss of a loved one. But that was considered a just normal reaction. It still might be a normal reaction to things. But we're still, in order to make that diagnosis reliable, we're going to toss that criteria out the window and say the external circumstances that there don't really count. But we are still going to look to make sure that this isn't a different psychiatric diagnosis or another physical diagnosis. So basically, the first thing is for any psychiatric diagnosis in there are basically always going to be these 3 excluders. So 1, is it caused by another general medical condition? 2, is it caused by some sort of other chemical we put in our body, either prescription medication or drug of abuse? Or is it actually better explained by another condition that's in the DSM? The DSM, by the way, is structured sort of with the excluding diagnoses first. So within there, we'll look at bipolar disorder, for example, if you have bipolar disorder, you can't have major depressive disorder, because bipolar disorder has as part of it both major depressive episodes, but also manic episodes. So if anyone has ever suffered a manic episode, then by definition they do not have major depressive disorder. They have bipolar disorder because that's bigger. And in a different lecture, I'll talk about bipolar disorder and what exactly mania is. But sometimes that gets confused where people think that manic depression means like sort of severe depression. It doesn't. Mania is actually the opposite of depression, which is why we changed the name to bipolar disorder, as these sort of ups and highs. So in looking, if you've got somebody with a major depressive episode, one of the first things you want to ask is, have you ever had symptoms that are sort of the opposite to this? Have you ever been sort of high, even though you weren't using any drugs, for going on really feeling like super abnormally good for weeks on end? Because if you have that, then you might have bipolar disorder, not major depressive disorder. There are other conditions, by the way, that are sort of more obscure, like schizoaffective disorder, depressive type, that could subsume this, but bipolar is the major excluder. And it's really important to exclude because the treatment for major depressive disorder can actually make bipolar disorder worse. So we want to make sure not to miss that. So if you're looking at trying to define and diagnose major depressive disorder, make sure you're not missing bipolar disorder. The other two excluders that are in there to say this is not essential depression, not major depressive disorder, that are true in almost every diagnosis in DSM, is to make sure, again, that it's not medical and it's not due to a substance. And substances are the great confusing factor out there, because a lot of times people turn to substances to help them cope with a depressive feeling. So they may drink, and alcohol is a very powerful depressant. So someone might have just had one or two bad days, but they drank to try to deal with that, and it ended up actually making it worse. So now we don't know whether they really have essential depression, whether they have a major depressive disorder. We only know that they had a major depressive episode, which may actually be alcohol-induced depression. There are also a number of prescription medications can do this. How we found out that serotonin could be involved in depression was that there were certain blood pressure medications that depleted serotonin. And it turned out that pretty much everybody who was on these meds got depressed. Those ones are largely out the window, so I'm not going to talk about the specifics of them too much anymore. But in modern use, there are definitely drugs that cause symptoms that look like major depressive disorder all the time. Steroids. Steroids cause an initial high, and then you kind of crash down off them, and people can look very depressed. A lot of chemotherapy drugs, interferon in particular, can definitely cause depressive-like symptoms. Accutane, the acne medicine, can cause depressive-looking symptoms. So that's not major depressive disorder, because that's a different condition. The treatment for that is to get somebody off the offending agent, get them away from alcohol or get them away from the interferon. And obviously, we understand that sometimes that cannot be possible, that the interferon's more important because they've got to survive their cancer. But we're not going to treat that the same disorder, because really the biochemical thing that's there is obvious. It's this external biochemical. We're not going to try to fit your internal biochemistry by itself in that regard. So we can have these substance-induced things. And then there are also medical conditions that can cause this. For example, if your thyroid is off, that people whose thyroid levels are low are sad, or they're lethargic. They sleep all the time. Everything is sort of slowed. So that looks like major depressive disorder. And again, they can actually meet criteria for a major depressive episode, but that episode is not caused, essentially, it's not caused by itself. It is driven by this lack of thyroid hormone. And again, the treatment, and therefore, is to fix the thyroid. Similarly, they could have a particular brain injury that could lead to this. And some things can be mimics that can sort of overlap. For something as simple as anemia, low red blood cells, is that somebody with anemia is going to be fatigued and run down all the time. So otherwise explained by a general medical condition, And there's a long list of them, but those are the major ones that we think about are anemia, thyroid, often conditions of hormones, basically, and neurology that can otherwise explain a major depressive episode. And if you got another explanation or you have another condition, it's not major depressive disorder. But if you've met 5 out of these 9 criteria, you now meet criteria for a major depressive episode, and it goes on, and there's no excluders, now you have a major depressive disorder. Well, why do we spend all this time making this diagnosis? Why should you care? There was a great quote by Carl Jung that I love, which is diagnosis does not help the patient directly. It only helps the doctor to help the patient. So, though I would argue that it can help the patient, because sometimes sort of understanding yourself is the first step to recovery. But what it allows the doctor to do is to say, okay, we've defined it this way. Now I can look through the literature and see what thousands or hundreds of thousands or millions of people have been treated with in the past, and what helps people. If your depression looks like somebody else's depression, then what helped the other person might help you. So this allows your physician both to anticipate the natural outcome, will this get better on its own, and to pick treatments that have worked for people in similar situations. It also allows us to do a lot of research on this, to say, okay, if we take 100 people who have this and 100 people who don't, how are those two different? So let's talk about what that is. What is the natural history? What happens if we don't do this? And then we'll start to talk about treatment and how we change that. So what is the natural history of someone who has these symptoms? So if you go through this, you survey that and you go, that's very interesting. You have all these symptoms and you don't do anything. And typically, how long will someone stay depressed? You've been depressed for 2 weeks already. Well, typically, on average, it lasts somewhere between 6 and 24 months. So half a year to about 2 years. Now, definitely people can go way outside this. Some people spontaneously resolve just after a week or 2. And definitely in psychiatry clinics, you'll see people who've been dealing with things for decades. And that, on average, is the natural course. It lasts more than 2 years in about a third of individuals. Even if you did spontaneously recover, it's been 2 years, you feel better, great, about half those individuals will relapse. Will have another episode come up on its own. In terms of predicting who does get better and stay better, it's basically full remission. So if you have everything 100% better, then you're much more likely than other individuals to stay better throughout the rest of your life. If you're like, I feel better than I did a year ago, but I still feel pretty crummy, I still can't sleep, those sort of things, that is the very predictive of how you're going to do in the future. As a whole, by the way, this is a big deal. Major means major. The World Health Organization estimates that major depressive disorder is now the #1 cause of lost productivity in the entire world. So more so than pain, more so than cancer. Luckily, major depressive disorder is not as lethal as some other conditions, but it really does cause a great deal of impairment because it's both fairly common and it can be quite debilitating. And it still does have relatively high lethality. Somewhere between 5 and 15% of patients diagnosed with major depressive disorder will eventually die by suicide. That compares to about less than 1% of people in the general population who say commit suicide for a particular stressor or something else, that is a fairly rare event. But if you've been diagnosed with depression, your chances of dying by suicide go up, at least by about a factor of 10. So why the heck does this happen? If we have these episodes, what actually causes them? Well, the problem here is that we know that major depressive disorder is a defined pattern. It's a syndrome. And we're pretty sure at this point that it's probably not going to turn out to be one thing. This isn't like, AIDS was defined at the beginning as a syndrome, but it turned out to be universally caused by the HIV virus. The flu not always the case. So people who have flu-like syndrome, about 90% of them might have turned out to be what we now call the flu, which is specifically a disease related to influenza. But what they used to call the flu, just sort of this syndrome, could also be caused by hantavirus or other things. And in major depressive disorder, we know that it's going to turn out to be more like the old-fashioned definition of the flu, that there are a number of things that are going on. And we know that health as a whole is made of our body, our mind, our spirit, and our environment. But really all of these are the same thing. Think about the Matrix. It's like, what's real? What's not real? What do I perceive? Well, the fact is that really mind is, the concept of mind is made up of the biochemistry of our brain, which is our body, and how our intestine works influences how our brain works, influences how we talk. So I often think that something that's helpful in sort of understanding this metaphor and understanding how mind and brain and body are connected is the concept of why Pac-Man moves, and why thinking about things in different ways allows us to manage different things, even though there's really the essential thing. So if we see a Pac-Man machine, we want to play that game on there. We all know what it is. It's all one machine, right? And we see the little Pac-Man running around being chased by these ghosts. And of course, why is he moving? Well, the short answer is because I am pushing on the little lever that makes him move, right? So Pac-Man is moving because I said so, right? This external sort of spirit force, you might think of that. But on a more fundamental level, you can think about the physics of this. The Pac-Man moves not because of the lever, but because of alterations in the program. That there are little zeros and ones in the computer code, and if someone altered that code, no matter what I did with that joystick, that Pac-Man wouldn't move. That there is a code that drives that. But then, of course, in the code, there aren't really little zeros and ones in that machine. There are, in fact, little electrons that are moving around, that are eventually being translated to photons, to little pieces of light that project on that screen. So we all get the impression that Pac-Man moves because I'm moving the joystick, or because the ghosts are chasing him, right? But there are different ways of looking at this, and we can alter it in those different ways. I can alter how Pac-Man moves by altering the pattern in which I move my hand, maybe altering, in fact, the way that things that influence me, the way the ghost influences the decisions that I made. But also a computer programmer could go in there and type in different code, and no matter what I did with the joystick, Pac-Man could be doing something else entirely. And then finally, no matter what the computer programmer wrote, someone could go in and alter the hardware, could clip a wire somewhere, and would get entirely different results. So this is sort of a different practical ways that we can think about something that is being unified, but that you can look at different approaches to how to alter a particular outcome. So rather than altering the way that Pac-Man moves, we're talking about how do we alter the way that someone feels in terms of these persistent feelings of depression, suicide, not being able to sleep, not being able to eat, not being able to focus, concentrate, etc. So in terms of the biology, we have taken a look at people who have this and noticed that serotonin and norepinephrine levels are different. So sometimes the obvious thing is, well, why can't you just do a brain scan or do a lab test the way my doctor does influenza? And the fact is that biology is just incredibly variable. So if you take 200 people with a major depressive disorder and sample their brain fluid, and you take 200 people without, you can see that the people on average, the 200 people are depressed have lower serotonin levels. But if you look on an individual basis, there's so much variation. And even within the course of a day, you may have a high serotonin level in the morning, a low one in the evening. It's high after you won a tennis match, low after you lost it. And you're going to get very different outcomes in terms of serotonin levels. So anyone who can tell you that they're going to diagnose you based on a lab test is basically stealing your money at this point. They can help guide things. There are trends in that regard, and you'll see some genetic predispositions towards responding to particular medications, but not an exact science. So if someone thinks that they're going to a fancier clinic because they did genetic testing, you don't really believe them, basically. It can help guide things, but for the most part, what it can do is guide money out of your wallet. The biology does change how you think and feel, however, though. We know this. Part of the reason that we think that serotonin is involved is that when you add medications that increase serotonin, that of course depression tends to get better, and vice versa. If we take a medication that depletes serotonin, that we can create a syndrome that looks just like a major depressive disorder. So this is involved somewhere. But there's a lot of variations. Chaos theory, you can't predict the weather, never mind human biology and the gazillions of connections in there. There are more synapses in your brain than there are stars in the Milky Way galaxy. And there's a lot of variation there. So all of these external factors will interact in the way we think and feel. So in both directions. So if I give you a drug that lowers your serotonin, you will feel depressed. But also, if you win a tennis match, your serotonin level will go up. If you lose a tennis match, it will go down. The external world affects our biology, affects how we think. All of these things are intimately interconnected. So this allows us to come to different ways to treat depression. And again, sort of to break it back down into that sort of metaphor of Pac-Man, moving the joystick, altering the software, altering the hardware. We can think of, in terms of depression, a treatment. We can look at biological treatments, medications, psychological treatments, therapy, social treatments, looking at the external stresses, maybe not doing so many things that make you miserable. And sometimes we add to this the concept of safety. Because in the end, nothing gets better if you're dead. And if you remember earlier, I did say that 5 to 15% of people with a major depressive disorder may end up dying by suicide. So we also have to treat people sometimes by just buying ourselves time. And I'll do a separate lecture on when psychiatric hospitalizations and emergency interventions are necessary. But the first thing, in terms of treating major depressive disorder, to remember is that people have been getting better from these things long before we had psychiatrists. That real life is good therapy. Psychiatrists like to talk about your mother, right? Well, imagine if you have a good mother, at least, that there are lots of good things that a good mother would tell you in terms of keeping a healthy and happy lifestyle that are incredibly important in terms of treating a major depressive disorder. So you have to look at, working towards your goals in life, having purpose, avoiding unhealthy habits, specifically those other chemicals that we know could create a major depressive episode, not, drinking and using drugs that can deplete all of our happy biochemicals, cultivating healthy habits, having patience with frustration, and in general, of course, staying alive. Nothing gets better. And this is where therapy comes into play. And there are lots of different forms of therapy that can seem to be very effective and helpful for major depressive disorder. None of them has really been proven more effective than any other. Probably the most commonly used these days is something called cognitive behavioral therapy. Again, a whole nother lecture. But the bottom line is seeing a therapist, talking to someone who's a professional can be very helpful in this, and at many different levels. Psychiatrists can provide therapy, so can psychologists, so can social workers. Maybe Joe Billy Bob off the street can just as well. It's an interesting thing from experiments with primates that show that there's even a concept of a therapist monkey. So maybe even a monkey could provide therapy, but there are clearly things that we know are incredibly damaging in there. So there may not be a good or perfect therapist, the right person to talk to, but there are definitely a bad therapist out there, which is why it's probably helpful to have a professional in this, someone who their colleagues have looked and told them that you're okay to do this. We're not terrified of the things that you're telling your patients. AKA Dr. Laura Ingram, who, by the way, is not actually a psychiatrist or a psychologist. She's, I think, has a degree in physical therapy. And if you've ever listened to her radio talk show, will give advice that is just overtly horrendous from a mental health point of view. So you can be bad, but having somebody to talk to, in general, someone who, as long as they don't do horrible things, is generally very helpful in talking through this. But beyond all these different professions that can do things, there is a differentiation between psychologists and psychiatrists. So psychologists are talking doctors. They generally have a PhD or a PsyD, and psychiatrists are medical doctors. So medical doctors can provide medications. So, with therapy, we can help with anxiety, depression, coping skills, pain development. It's usually time limited in some ways, but it can be very, very effective. But oftentimes there seems to be a population that it does not seem to be helpful for, that you can talk all you want about your problems, but you still feel miserable. So for those folks, medications can be helpful. And it's really important to understand that antidepressants are not happy pills. That you can take all the antidepressants in the world and they don't turn you into Superman. That in doing them, if you take an antidepressant and your cat dies, you will still feel sad. But vice versa, they shouldn't numb you out. You shouldn't be a zombie on these things. Now, occasionally, people go for a loop on antidepressants. Yeah, sometimes people with bipolar do. That's where I talked about why it can be bad, and some folks can knock you into a manic episode. But in general, it shouldn't. Antidepressants are probably better described as unstick your brain pills than really, anti-sadness pills. They stop someone from being stuck and feeling this way all the time. Maybe allow therapy to work. If your brain is sort of stuck as gears there, the medications can sort of be the oil on the gears that maybe allow them to turn, but then either through those regular life things that you would do, go out, go for a walk, fly a kite, that sort of thing, or talking through your therapist can actually start to drive those wheels forward now, once they're properly lubricated with a little medication. So they can help restore what is, quote, normal brain biochemistry. But they are still medications. All medications come with potential side effects. Anyone can have any side effect to any medication. There are interactions with these medications where, two particular ones that might be great on their own can actually be lethal in combination. There are particular side effects to each one that we need to be aware of. The one that we really have to be careful of is that there is a population for whom antidepressants really make things worse rather than better. This is why you can't just buy these things over the counter, and why physicians, to some extent, are really pushing back on the idea that people with less training should be prescribing them. And that's a separate debate, and if you're a nurse practitioner, more power to you in that. But, in general, a psychiatrist will have done 4 years of medical school, about 80 to 100 hours a week, and then about 4 years of residency, about 80 hours a week, to learn how to do this, whereas some other professionals may only get 400 hours of training total, of which half of which are online, which may be enough. If you're focused entirely on antidepressants during that 400 hours. But the bottom line is, with these medications, they're not to be used casually. You do need to be aware of the risks as well as the benefits with them. Primary care physicians can prescribe a large number of them. Selective serotonin reuptake inhibitors in particular, Prozac, Paxil, Zoloft, or fluoxetines, sertraline, paroxetine, those are the generic names versus the brand names, really changed the game in terms of the medication treatment of depression, not because that they're any better than the older medications, but because they were broader spectrum and safer. So you didn't have to worry as much. There's still problems with them by all means. You have to be careful, but often can be done in primary care these days. If you do take a medication, what can you expect? Well, they probably do start working the first day. There was this sort of belief for a while that they don't start working at all for 4 to 6 weeks. And if you look at any sort of individual trial, that seems to be the case. It's like, wow, the curve doesn't really seem to really tick up for 4 to 6 weeks. But it's not actually the case. If you add all the trials together, what you can see is that they start to separate. Is that basically there's improvement right at the beginning, and versus placebo, people will naturally recover from things. It's just that those curves get wider and wider over time. So this is the tendency of people on antidepressants to improve. This is the tendency of people to naturally recover. You may not be able to tell natural recovery and natural variation day to day. with these medications till about 4 to 6 weeks, and they will continue to work for months and months, getting stronger and stronger. So usually someone who is responding to one will be on them for 6 to 12 months for a first episode before we try to taper it. Some people are on for a lot longer. If you've had 2 or 3 episodes, if you had 3 recurrent, for sure, that we recommend being on them for life, because they seem to be just coming back every time we get rid of them. But on a first episode, you have a pretty good chance of getting off of it. So it doesn't mean you have to be on these medications forever, but it is a reasonably long-term commitment. You have to look out for side effects. You have to make sure you're actually benefiting from it. If you've been on this for 4, 6, 8 weeks and there is no benefit, then you may want to transition to a different medication or a different form of treatment. Okay, so to review, a major depressive episode is worth defining because it allows us to see things reliably in a valid way, allows us to communicate and lead treatment, predict what's going to happen. So it's worth defining a major depressive episode the way that the Diagnostic and Statistical Manual is. That means 5 out of 9 symptoms that include at least consistent depression or lack of pleasure and hedonia for at least 2 weeks straight that cannot be explained by other things. If you have a major depressive episode and you want to treat it, we can look at biological treatments, antidepressants, which can be helpful. Start to see a noticeable improvement usually in about 4 to 6 weeks, but will continue long term. We can have side effects. Therapy can be helpful, a lot of different varieties of learning to change the way that you think. We can look at external interventions about just keeping yourself healthy, looking for those healthy habits, avoiding people who make you miserable, being more with people who allow you to think positively, all of those sort of natural environmental things that are very helpful. But the big thing in all this is that major depressive disorder can kill you. So we always need to ask our patients about suicide, about thoughts of death, and make sure that they stay safe or nothing is going to get better. But as a whole, this is a common and treatable condition. Going to a psychiatrist for something like this does not mean that you're crazy. It just means that you have a condition for which we can help, that pattern allows us to recognize a way that we are allowed to help people or can help people if you allow us to do it. Whole joke of how many psychiatrists does it take to change a light bulb? 1, but the light bulb has to want to change. The patient engages in this, the client engages in this. They have a lot better chance of getting better and leading a very happy, normal life where they don't have to feel depressed all the time. They don't have to have these criteria for major depression. Thank you, and we'll be back soon talking about bipolar disorder and other psychiatric conditions.